But finally, since we were mandated to move to the new Medicaid eligibility process by the Affordable Care Act, we have seen a dramatic downward trend in terms of the number of applications that we're receiving. And I think that has a lot to do with the cumbersome nature of the new applications. The Affordable Care Act mandated that states use a single streamlined application for both the exchange and for Medicaid. That single streamlined application is about 4 times longer than our previous application. It originally included required fields such as your employer's tax ID number. We've worked to try to streamline that process as much as possible with CMS. But it is a daunting task for people who are coming in to fill out those applications, and also just the systems issues we've experienced in terms of the transfer of those applications from the federal data hub to the state level have been significant. But they are improving, so we look to see how this will continue in the long run. And we are trying to make sure that those who are eligible for Medicaid are brought into the system as quickly as possible, particularly pregnant women for whom it's important that we start that prenatal care early. But I want to touch on the LSU public-private partnerships. And before I sort of dive into these slides, which highlight what we see as some of the big successes of that effort, I want to give a kind of a brief update on where we are in terms of our conversations with CMS and the federal government about the financing arrangements. As everyone saw, that CMS did issue a disapproval letter of what we call a state plan amendment, which is the document that governs the payments and services in the Medicaid program, including services or uncompensated care payments to hospitals for delivering care to uninsured individuals. Those state plan amendments were fairly straightforward in that it shifted the payment of those uncompensated care payments for uninsured residents from public institutions to private institutions. And states across the country have utilized private institutions, including Louisiana in the past, to deliver uncompensated care payments for care for the uninsured. The issue itself was really very little to do with that methodology and those state plan amendments, but CMS had a lot of questions about the advanced lease payment arrangement for the hospitals themselves. As part of the public-private partnerships in the hospitals across the state, in the instances where the public-private partner was going in and operating the previously state-owned and operated facility, a fair market value assessment was conducted to determine what would a fair lease payment be, and the private partner pays a lease payment to the State Division of Administration for use of that facility. In some cases, those arrangements involved an advanced lease payment and as a way to ascertain the good faith effort of that partner and their commitment to serving those individuals in the long term. CMS has questioned those payments as provider-related donations, which are prohibited by federal law. Louisiana has continuously contended that these are not provider-level donations, that they're fair market value lease payments paid by the state, and they're separate and apart from the reimbursement methodology we employ for the care of Medicaid individuals and the uninsured that those partners are taking care of. CMS has been confused on that issue, and we've had lots of conversations with them. Since the disapproval letter was issued, we've had several very productive conversations with CMS. They have been very clear that Louisiana can continue on its path of public-private partnerships. They provided excellent leadership and clear guidance in terms of what our next steps need to be, which involve the immediate resubmission of new state plan amendments that will make it clear that the payments for these services are separate and unrelated to the agreements with the hospitals for the lease arrangements. And with that submission, we believe that will answer all the outstanding concerns, and we'll be able to move forward with both the past and prospective payments for these services. So we were very relieved and very comforted by the leadership that CMS provided in that respect. Now I want to talk a little bit about what those partnerships have meant for people in Louisiana, particularly the uninsured individuals. In Baton Rouge, Our Lady of the Lake has partnered to assume charity care and graduate medical operations. Since that time, and this partnership is a little over a year old, they have served, and I think this number is even higher now. I think it's more than 100,000 people. They've opened a new 24-hour urgent care center in North Baton Rouge near the site of the old Earl K. Long Hospital. They've opened a brand new LSU Medical Innovation and Education Center on their campus here in Baton Rouge, and they are on track to become a level 1 trauma center, which will serve all residents of the region. We've also seen decreases in wait times, particularly for pharmacy services. People are able to access prescription drugs much faster than they were in the old system. In Lafayette, Lafayette General Medical Center is our partner. They have reopened numerous clinics that had previously been closed by budget cuts, including a pediatric and orthopedic clinics. They've hired a new oncologist. They have plans to become a level 2 trauma center for the region, and they have also served many thousands of patients through that partnership. In New Orleans, Children's Hospital has increased their ER capacity. Children's Hospital is running what is currently the interim Louisiana hospital that will be replaced by the new academic medical center next year. And they've increased the ER capacity. They've reopened 75 hospital inpatient beds. They've also reopened 9 inpatient psychiatric beds at that facility. In Lake Charles Memorial has also opened a new urgent care clinic at the site of the old W.O. Moss Hospital, which is now closed. They've opened several new specialty care clinics, including an orthopedic clinic and a breast health clinic. They're also working to significantly reduce wait times and backlogs for services. In Homa, Oxnard, and Terrebonne General have partnered to take over operations at Chabert Medical Center. That has resulted in numerous improvements, including new clinics, hiring of new physicians, a cardiologist, a urologist, family health physicians to provide primary care. They've updated much of the old and antiquated equipment that the hospital used, including 2 new mammogram units that have been installed. In Shreveport, a Biomedical Research Foundation stands a little bit apart as a unique partnership arrangement for both the Shreveport and the Monroe Hospital. They're the only partner that is not a hospital that already exists. They are a nonprofit foundation. They have brought in Alvarez and Marsal as a consultant in terms of the transition in running the hospital. And they have also seen great new strides in terms of reducing wait times in the ER, reducing wait times for CT and MRI scans. In some cases, these waits were 3 and 4 months, and they're down to 2 to 5 days. So significant improvements in the amount of time it takes to get in and get those critical diagnostic testing done so that the cancer or other advanced stage disease can be treated sooner, and the chances of survival are increased tremendously. They've also opened a new orthopedic clinic, cardiology, and urology services in Monroe, and those services are now serving people that in that community had to travel to Shreveport or further to get those services. And really, I think what this shows is that these partnerships are yielding tremendous new services, reduced wait times, reduced backlogs, vastly increased efficiency in terms of the throughput. In some cases, I think in Monroe, we saw where physicians were seeing 10 to 12 patients a day. That's been increased to 26, 28 patients a day. So as you can imagine, that has a tremendous impact on wait times and the availability of services. And so they brought their expertise in running these facilities to bear. They brought their flexibility as private enterprises to bear. They can staff up and staff down to meet the demands of the seasonality or the market. And they can move swiftly to replace equipment or to open new services as the market requires it, without having to go through a lengthy capital outlay process or just the general bureaucracy of state government. Oh, I'm sorry, 2 more. Bogalusa transitioned in March of this year. It's now called Our Lady of the Angels Hospital. It is being operated by Franciscan Ministries of Our Lady. We're excited to see some of the things that will happen in that partnership. And then next month, we will be transitioning fully the operations in Alexandria at Huey P. Long. That hospital will close. The legislature just recently approved that resolution for closure. And those services will now be provided by Rapides Regional and Christus St. Francis Cabrini in a partnership between those 2 hospitals. Today I talked about what Louisiana is seeing in terms of some of the impacts of the Affordable Care Act, looking at both at the national level and at the state level, what some of our concerns have been with the rollout of that law, and some of the long-term concerns we see about its viability, particularly as it impacts the Medicaid program. I also talked about some of the major transformational reforms we've launched over the last several years that are really yielding results in terms of improved health outcomes and a better delivery system for the people of Louisiana. That includes the public-private partnerships in the LSU hospitals. It includes the rollout of Bayou Health, our Medicaid managed care initiative, and the Louisiana Behavioral Health Partnership. I also talked about our upcoming initiatives, which include the rollout of our managed long-term care supports and services system. That's going to be a big reform that impacts people who are elderly or have disabilities and try to better coordinate their care to reduce costs, to reinvest those savings to serve more people. And finally, I'll talk a little bit about what we see as the future of healthcare in the state and the country, and how we believe we can continue to work toward a healthier Louisiana through a new initiative that we've launched called Well Ahead.
The Our Lady of the Lake LSU Cooperative Endeavor Agreement was about graduate medical education, and so now over 270 residents and medical students are on the campus on a daily basis. And as a part of that, the ambulatory outpatient program has occurred. Since the beginning of the program, we've had over 200 outpatient visits, 200,000 outpatient visits. Pharmacy increases, being able to turn around medication fills within 60 minutes. The opening of the 24-hour urgent care center up on the North Boulevard campus, which sees almost 30,000 people a year.
Would you describe this as a successful partnership?
Absolutely. It's been a wonderful relationship between Our Lady of the Lake and the state and the federal government. The community health needs assessment is very interesting in that Baton Rouge took the perspective that all of the hospitals in this community participated in one community health needs assessment. As you look across the nation, there are about a handful of communities that actually collaborated on a single community health needs assessment. So very proud that Baton Rouge, under the auspices of the Mayor's Healthy Cities Initiative, had Ochsner Medical Center, Our Lady of the Lake, Women's Hospital, back then Earl K. Long was a part of the process, Baton Rouge General, and Lane all participated in a single community health needs assessment that identified 10 priority areas and then went further to use the Institute for Healthcare Improvement to say these are the 4 community-based efforts that we will attack as a community. And those are HIV/AIDS, mental and behavioral health, overutilization of the emergency room, and obesity. So from that perspective, certainly meet the intent of the ACA. And for this year, when the group got together, because it's every 3 years you have to undertake this community health needs assessment, for 2015, we've agreed that we will do that process again as the Mayor's Healthy Cities Initiative. And for the first time this year, we have a single implementation plan. The government doesn't require a single implementation plan. They require individual hospitals to have an implementation plan, but we agreed as a community that we would have one implementation plan, and then we would all speak to our efforts around that. So that's pretty exciting because we've not been able to identify any other community in the nation that has a single implementation plan.
Regarding the community health centers, it's kind of twofold. There's an operational aspect and then certainly the patient aspect. Operationally speaking, there was quite a bit of attention and responsibility thrust toward the community health centers. There was a certain expectation from our federal partner, the government, to instigate and train a number of community certified application counselors. And they were to go and do a great deal of in-reach and outreach and educate not only the patients but the community about certain aspects of the Affordable Care Act, but also about specific terms around the marketplace. So health literacy became a focal point of the community health centers. Not only the providers trying to share some of that information and instruction, but again, trying to reach out through, there were several new partnerships. We started advertising on the radio. We started working with Together Baton Rouge. We worked with the Navigators. We worked with various church organizations and so on. So anyone that would allow us to get in front of our patients outside of our health centers became a partner going forward. We learned a great deal more about our patients and some of the circumstances that they live in. Most of these patients did not have an earlier access or experience with most health insurance, even, what's the difference between deductible and copay. I might go back and just say, for those of you that are not familiar, there are 30 federally qualified health center organizations in the state. We operate approximately 140 sites around the state, both urban and rural. 40% of those patients are Medicaid eligible. Another 40% are uninsured. So quite frankly, out of the 300,000 that we treat, well over 100,000 have never entered the insurance market and are considered self-pay. And so typically when those people come in, they are offered our services on a sliding fee based on their income. So that is their insurance, the way they look at it, coming into us, providing proof of income, and then having some sort of discounted price. So explaining an insurance market, explaining who might be eligible and who not. Of those uninsured, approximately 75% of them fall below 100% of poverty. So we became experts on income levels, marketplace eligibility criteria, and then tried to convey that to the patients and follow up. Because, without going too much into it, Medicaid expansion was initially part of the Affordable Care Act and expected, we had to go and explain to a lot of people what was eligibility based on income and when it would apply and when it would not, and then try to find those services for those that were ineligible for the marketplace. So as operationally speaking, for lack of a better term, I know some of our health center directors are here today, in a lot of ways it was business as usual. We were still trying to follow up with this certain patient population, explain to them their responsibility, and explain to them the facets of the insurance. Now, operationally speaking, again, trying to take on new staff and new services, and then, continuing, when we talk about access to care, there's always been an effort in trying to reach our population and provide them additional access to additional services, especially around specialists. So with the disruption of all of our referral systems throughout this process, we've got a lot of issues trying to renegotiate contracts. And again, when the marketplace opened up, that opened up a lot more contracting opportunities and responsibilities with different plans. So the health centers had their own learning curve in addition to trying to educate the patients through, this continuing transition.
My job is completely different from the job of most of the people in this room. Whether I'm in the office or in the operating room, I am doing the best possible job that I can do for one person. And I know that I'm looking at a room full of people who are tasked with providing the best possible health care to thousands, and also calculating how to pay for it. And so I express that sympathy to you when I tell you that my point of view is really from the doctor's lounge, from the exam room, from the operating room, and I do not know how you pay for it. So a couple of things come to mind. When you talk to doctors about their experience working with patients that have this new insurance coverage, I think that you all might be surprised how many physicians will say that they haven't seen a patient yet. I won't belabor the very, very well-documented delays, postponements, changes, amendments. All of this on the ground has the consequence that a lot of doctors are seeing their first couple of patients with this coverage or have yet to see a patient. And thus, we may be able to discuss this and have a better analysis at this convention next year than today. Secondly, when I speak to doctors about their experience with these products, those of them that have seen them suggest that it's like just another insurance, and so they're going through pre-authorization and billing and things like that. And what they're telling me is that it's really quite ordinary, and I consider that to be a good thing. Just another insurance, quote unquote, and I think that's what they were supposed to be. Now. On another note, and you heard from my bio, there is a disease that I have a particular interest in that the Affordable Care Act plans have a negative impact on, and that is access to care for the treatment of obesity. Blue Cross Blue Shield of Louisiana was used as a benchmark as our plans were designed, and as a result, there is no coverage for nutrition, exercise, weight loss medications, or bariatric surgery for the treatment of obesity in Louisiana. 37 states in the country have at least one Affordable Care Act plan that provides bariatric surgery. So I'm not suggesting that Louisiana consider anything that's particularly radical. Why those states are doing that are because of the weight-related medical problems that we can put into remission or ease with treatment. I can put type 2 diabetes into remission within hours of surgery. I can improve high cholesterol and delay or eliminate the heart attack, strokes, and death that go along with that. I can take weight off of weight-bearing joints and prevent or delay joint replacements. I can decrease the risk of some of the most common cancers. And so I would argue that this is something that your industry should look at again. And I do believe that it will save you money, but what I care about more is that it will ease the suffering of lots of patients. And so that's something that I think should be revisited.
So what is a navigator? Navigators were defined in the Affordable Health Care Act as in-person assistants. Our job was to provide community outreach and education to people in the community to help them understand and to navigate the Marketplace website, and then to also help them to understand what the qualified health insurance plans were and what the differences in those are. We are not a political entity. Our role as an AHEC is not necessarily for the ACA or against the ACA. We start off our presentations by explaining, if you're not happy, contact your congressman. We're not our job is to help people to understand that health literacy.
I remember a year before the ACA was passed that we walked into Congressman Bustani's office and he said, "So you are the people that are going to lose your jobs." And I said, "Over my dead body." And those that know me and get emails from me every day, sometimes twice a day, you know I've dedicated my life to giving you what you need to succeed. A year later, we were in Washington and HHS spoke. They said, "We're going to create an entity called Navigators. We're going to create this entity because agents will not talk to the poor, will not go to rural areas, and do not speak foreign languages." I'm very happy to say that half the agents this open enrollment enrolled the Vietnamese fishing villages throughout Louisiana. So agents and brokers, we do all those things. Navigators were created, and Bruce knows that I have tried to work with him and tried to partner with him, and we're going to continue to do everything that we can. My message is that agents and brokers are still the boots on the ground, that we are here to help consumers, that we're going to be ready for open enrollment come in November, and all you need to do is call an agent. We're the experts, and we're here to help. The premium is the same, so agents are free. The commissions are already built into the premium. It doesn't cost anything extra, and they are the experts. They've been around, they have the education, they have the insurance D&O to protect them, and they have all the knowledge.
We've seen an incredible response. We've had a number of people who have wanted to, who have come to us to make sure that they have access to that health insurance. And so we've helped people. Most of the people that we've worked with are those that have not had insurance before. So there was a very low literacy on insurance. So we've had to explain the difference between co-pays, co-insurance, things like that, help them to understand and get them enrolled through a very difficult process.
My message today is taking it to the streets to show how it's such a crucial role for insurance agents, navigators, all of our partners. There's a place for everyone. And my message is just to let people know that agents are educated. Agents have spent the last 4 years studying the Affordable Care Act, so they'll be able to help their clients in 2014 this year as it became effective. January 1, the individual mandate that we've heard so much about came into effect. And so we have worked to try to help people that previously we could never help because of pre-existing conditions and things like that. We are now able to go out to individuals and sign them up in insurance plans, and even work with employer groups that maybe have found the costs so high that they can no longer afford to offer benefits, and give them the alternatives, what they can do.
I think you're going to have to continue to work on the plan to fix some of the flaws in it. Obviously, there's some tax issues for some employers that have been very burdensome, but I feel personally the law has got pros and cons in it. There's winners and losers, just depending on what side you fall out. The exact legislation we need, I think you're just going to constantly see over the next 5, 6, 7 years that hopefully the law will be tweaked. We can do away with some of the things that are not so good in it, and keep the things that have been very good and helpful. And it'll be a lot like Medicare. As it's evolved, it's gotten better. My prayer is that this will be the same for the Affordable Care Act.
We'd like to see there to be more understanding of the risk levels that we're undertaking, greater visibility into that. Our goal at Blue Cross of Louisiana is to maintain the private sector health insurance market. We believe that it's better in the hands of the private market than in government. So we're doing everything we can to keep our prices affordable and keep private health insurance viable.
We've noticed a lot of employers making a move toward being self-funded. We've noticed a gradual, minimal but gradual decrease in fully insured business while the ASO business moves up. And we've noticed that as a national trend. But again, the decision making is still, that process is still going on for a lot of employers. And with mandates and transitional relief and those sorts of things being pushed off into the future, I don't know that we'll have a clear snapshot in the next year or two.
The coverage will be similar to everything that the insurers are doing out in the public. Hopefully we'll be able to provide the same or better than anyone else is doing in the marketplace.
The Affordable Care Act is a process. It's not a one single thing. We need to look at it and move forward. And we need to move, as the CEO of Ochsner on the North Shore said, move towards more of health care rather than sick care. And in doing that, we need to look at all the processes, all our markets, and work with our providers and move forward on the whole issue of providing health care to our populations.
Just speaking on behalf of the community health centers, I think that there needs to be some recognition of this population and the patients we serve, and to make things easier and streamlined and a little more consistent.
Very good. When the conference is over, what would you like people to keep in mind?
That community health centers and other health providers are there for the patients, and I know that a lot of this is getting wrapped up into insurance and procedures and laws and politics, and it really is about the best care for the patient.
More or less mixed reviews for the ACA after 1 year.
No doubt about that. The ultimate proof is in the pudding, as they say, and that's yet to be determined. As they also say, the fat lady hasn't sung yet, so it is not over. We have an election coming up this fall where candidates are running yay and nay on the Affordable Care Act all across America. And the outcomes of those elections will certainly influence the direction. The president will still be there for 2 more years with his veto pen at the ready, but the momentum will be sent in one direction or another relative to support or unhappiness with the Affordable Care Act. The polls would indicate it's more unhappiness than support, but we'll know more after this fall's election.
I'd like people to keep an open mind. I truly would like that very, very much. I think that it's important for people to take away the R, take away the D in terms of being so political about a situation that is, I think, evolving. And give it some time, give it some rest, and watch it like any other huge and massive comprehensive change. Watch that change develop over the time. Be ready, be reactive and proactive at the same time, so that as we can find problems in the system, we can quickly correct them. But let's give the system some time to work itself out.
We are the experts, and they can reach out to us either online through an email at www.ldi.la.gov or by just calling us through our 800 number, 1-800-259-5300. We can answer their questions. We can give them direction and guidance on what their rights are, what's available to them, what's not available to them under state law as well as federal law.